I want to try and give you a quick summary of this PBM story that we were talking about, and we can come back and talk about it more in detail. It's an issue that's passionate to many, that stirs great passion in many of you. The crux of the story is this. The Columbus Dispatch, a newspaper in Columbus, Ohio, took on an investigation in 2018. They gathered confidential reimbursement data from dozens of pharmacies, compared them to Medicaid claims data, and determined that there were 2 PBMs that were charging the state a lot more for drugs than they were paying the pharmacies that had bought and dispensed them. Ultimately, the Ohio Department of Medicaid fired CVS Caremark and Optum Rx, and they devised their own PBM in which they unbundled the services that had been provided by the big PBMs to create transparency and ensure that contractors were not imposing huge markups as they had done back in 2017. And ultimately, it led to lower costs for end users, saved money overall, and gave independent pharmacies the reimbursements that they were needing to be able to keep their doors open. So, again, we can go into more detail on that. But we've got a guest right now, and somebody actually that might be able to kind of weigh in on this conversation a little bit. Richard Robertson's president and CEO of the Mississippi Hospital Association. Great to see you again. Good morning, Richard.
Hey, good morning, Richard. Good to see you as well.
Thanks so much for joining us. This is certainly not where we want to dwell, but hospitals do play a role in this conversation about pharmacy benefit managers and the middleman and the good of them versus the less good or the difficulties that are imposed by them. Does MHA have a stance on PBMs one way or the other?
Well, look, Richard, I'm kind of tempted to paraphrase the soggy sweat whiskey speech. We've got some friends on both sides of that equation. We certainly run pharmacies in our hospitals. We've got independent pharmacists in our small towns, especially, that work very closely with our hospital members in rural areas, play a vital role in all kinds of different programs and partnerships with those hospitals. And then we've got relationships on the insurance side too. So we have a unique perspective, I think, on this issue where we're involved in some of the things on both ends and working with providers on that. There are certainly some things that need to be reformed in many areas of healthcare, PBMs and pharmacy benefits being one of them. We're active every day trying to make sure that we're able to purchase drugs at a very low price. And we're very pleased this year. A part of some of the PBM reform that we were able to get this year was on white bagging and brown bagging legislation. And that's a practice where the insurance companies will essentially send the drug or ship the drug directly to a hospital or a provider's clinic. And then that provider has to store it. And it's all done in the name of saving cost, supposedly. But it creates some issues for providers where, let's say you're treating a cancer patient and they're coming in for infusion treatments and the shipment doesn't arrive in time because the provider didn't have control over it because someone else was saying, well, it's going to be here at this date and just trust us, it's going to arrive, or you got to store it. And then when it does arrive, you've got to shoot the patient, shoot up the patient with that drug. I say all the time when we talk about this issue, I can't go into Firestone and buy a set of brakes at AutoZone and take it to Firestone and say, hey, just put these on my car. Trust me, they're okay. That's similar to what's going on with some of that. But our legislature this year said, you know what, we're not going to let that happen anymore in Mississippi. We expect some cost savings from that, but more importantly, we expect better outcomes for patients. And that's really the type of things that we've been focused on, is figuring out what makes sense, common sense-wise, what's great for the patients. Where do we need to do that? I say it every time I talk, and was speaking yesterday to a hospital board, and I think most importantly, we got to keep the patients first. If we get the patient experience right, everything else is going to fall into place, and that's where we try to land.
Is it fair to say that transparency and a level playing field are not too much to ask for, kind of across the industry?
Absolutely. Yeah, I mean, I think in so many things with healthcare, the transparency piece is a big part of it. We have been active in that space over the last several years, actually going back to 2016 on some reforms with public records and open meetings and how it impacted public hospitals. And, there's some things that from a business standpoint, if you're having business discussions about future business projects and recruiting physicians and adding on services, those need to be protected as any other business would protect their financial interest and in conversations regarding next steps from a strategic standpoint. You don't want to necessarily get into those things, but at some point they do come out, they do get revealed later on in minute publications or other things that you file. We've helped stand up a price transparency website and have promoted that with our membership. So those things are very important, very crucial. And look, in Mississippi, the government, whether it's Medicare, Medicaid, or TRICARE, pays for about 70% of the cost of health care. It's publicly funded, and the public has a right to know on many of these things.
Mississippi is not 100% unique, but I do think that there are some unique things about our state in terms of the healthcare system. There are places where you have exceptional hospitals and exceptional healthcare systems. Those usually are in larger areas in terms of population. But you've also got places that are incredibly underserved. We know that the plight of rural healthcare in Mississippi is a difficult one. What is the biggest issue right now? And I know there's probably a list of issues that you could tick off, but at the top of the list right now for the healthcare system in Mississippi, specifically as it pertains to hospitals, what is the number one concern for you?
Well, I will say this first. Excuse me. The hospitals across the state do a really good job of holding the line on cost. We're the lowest cost in the country. Excuse me.
Get a big drink of that SuperTalk.
I'm telling you, it's early in the morning.
Magic for the vocal cords. There you go.
I didn't loosen up the voice this morning before I came in. The hospitals across the state do a great job lowering their costs. We're the lowest cost hospitals in the country. It typically averages about $1,400 a day. The next closest is South Dakota at about $1,700 a day in expenses. So hospitals in Mississippi do a great job with maintaining the lid on cost, and we do that because we have to, because revenue is low. As I said just a second ago, 70% of the 70% of the revenue is going to come from government payers. Typically, they aren't the best payers. Now, there's some exceptions to that, especially with the Medicaid supplemental payment program that's been a lifeline for the industry over the last 2 years. Hospitals pay a lot of money, hundreds of millions of dollars in taxes to fund those supplemental payments. So it's not entirely off the back of the hospital. We do have to pay taxes to fund that, but the return on that, because of the match rate, makes that very viable, and that has been a lifeline, and it helps true up the Medicaid payments to make it more of a commercial rate payment, which again is just vital. So revenue is the big thing. I'll say this though, when you look at some of the quality scores that have come out across the state, two of the highest rated hospitals in the state for years have been Baptist Hospital in Columbus and Baptist Hospital in New Albany. So not necessarily the big urban centers. Certainly they do a great job in their community, and they have very, very consistently been the two highest rated hospitals in the state for a long, long time. And so we talk a lot about the big hospitals, the 400, 500, 600 bed hospitals, many of whom also do a great job. But it's, I think it's worth saying that you can receive excellent quality care no matter where you are in Mississippi. And was just down at Field Hospital yesterday in Southwest Mississippi, a facility that was built just a little over a decade ago, and it is a beautiful campus. And those patients are being very well cared for down there, and was also in Copiah County, down in Hazelhurst, and another beautiful campus. Their community supports that hospital, and you can receive excellent care there as well.
What do you make about the legislation that Senator Wicker is introducing right now, the Spark program that would give the opportunity for more specialists in rural healthcare settings in a way that their student loans are repaid, so that they don't have that burden and maybe choose to work in a smaller or a more rural setting?
Yeah, I think that a program such as that is great. We've had some different programs through the years in Mississippi. We currently have a rural physician scholarship program that accomplishes some of those same goals, which essentially is to help pay for the education if you're going to stay in a rural area. So those programs are vital, and we've got hundreds of physicians in that program right now. They stay in Mississippi. What we'd like to see more of is a distribution of those physicians across the state into some. We've got rural and we've got really rural, And so there's some really rural areas that are very heavily challenged that we need to get more physicians into.
Visiting with Richard Robertson, President and CEO of the Mississippi Hospital Association. We will talk at least around DOGE when we come back, the Department of Government Efficiency. We see money that's being cut in lots and lots of different areas. We know that changes are coming to Medicaid, Medicare. What is that going to look like? What is MHA helping its members prepare for? We'll continue the conversation on the other side of this timeout. Mornings with Richard Cross on SuperTalk Mississippi. Back with you, Mornings with Richard Cross, SuperTalk Mississippi, streaming at supertalk.fm, SuperTalk TV. If you've used an AI platform for anything, you know that there's a function that you can ask for help. Whether you're talking about Grok on X or ChatGPT, and you can take a really complicated subject and say, hey, explain it to me like I'm a fifth grader. Richard, I'm going to ask you to do that. I'm going to ask you to be AI here just for a second. We'll get to some of those cuts in a second. If I want to buy a brand new leather football, let's say it costs $100. That leather football costs $100 at my local sporting goods store. I can buy it on Amazon for $100. I can go to a sporting goods store in Seattle, Washington, and it's $100. And it's $100 in New York. There might be a little bit of variation, but basically that football is $100. But in the healthcare world, if I get a kind of a standard service at a hospital, whether it's an x-ray or a blood test or whatever, it might cost me a certain amount at my hospital in Oxford, a different amount in Seattle, a different amount in New York, a different account if I'm on Medicaid, a different amount if I'm on Medicare, and a different amount if I'm on private insurance, and then, there's the cash price. Why is there so much variation in the cost of a service within the healthcare world?
Well, I don't know if I can do as good a job
like
as
I'm
maybe
a fifth grader,
ChatGPT.
remember?
Yeah, I'll tell you this. In most cases, it's because you are not the one directly paying for the service. It's an insurance company. And they've negotiated different prices with different hospitals. If you were to walk in, if we got back to a world where it existed, 80, 100 years ago, you would see more of the standardization in pricing where you would go in and you would know what the price was. Now, 100 years ago, you might have been saying the price was 3 chickens or, something like that in the way the world worked, which, is true. I've got a good friend of mine whose dad was a country doctor, and that's how he got paid. He'd get paid in whatever the family he was treating and making house calls could pay him. Yeah. And so it might be a chicken. But, so where we've gotten now in healthcare is you as a consumer, if you have insurance, you're paying the difference in many cases between what your insurance company has negotiated with that hospital, and that varies based off of many different things. It varies based on the market you're in, the volume of consumers in that market that are insured by that insurance company, and it varies based on what the cost is for that hospital, because in some cases the hospitals are employing specialists. They're providing a wider array of services, and it costs more to provide those services. And then in some other cases, it's very different. So it's not a big box approach like you might find in some places. And you can go into different stores across the state, and if you buy something at a Main Street business, you may pay a different price than if you buy it at a box store. And so it's maybe not as widely varied, but you're going to see some distinctions there based off of purchasing power and how you do things. And hospitals aren't very different in that regard, where based on their ability to procure whatever the service is or the product is or the supply is or the equipment, they've got to pass that cost along, and there's some variation there. And I do think you're seeing some of that come back to kind of a middle ground where you're not seeing the just totally opposite ends of the spectrum cost. I think over the last several years, things like price transparency have come into place, and people are more focused on that. And but at the end of the day, it's a lot of it has to do with Medicare's negotiating one price, Medicaid's paying another price, Medicare Advantage is paying a price, commercial insurance companies are paying a price. So you and I don't go in and pay that price. We don't, we don't negotiate with that hospital or with that physician's office. And the same thing happens in physicians' offices, pharmacies. A lot of what you pay is based off of who your coverage is with. And if you don't have coverage, then you are going to pay kind of the sticker price, so to speak. And that will be pretty transparent. I say all the time, if someone in my family seeks health care and goes to a hospital, let's wait until we get that second bill, because it's going to have to run through the insurance process. So that first bill you get is typically not the final bill, because it's going to have to run through, and they're going to have to see what insurance pays, and then that changes a lot of the pricing that we have to pay out of pocket. So I don't know if I did as good as Gronk or Chat GPT, but it is hard to condense a complicated system. But I do think we've got to do some things better. We've got to do some things. In some ways, we can be our own worst enemies on how we have to present this to the patient. And like I said in the earlier segment, if we start focusing on what's best for the patient, all these other things are going to fall into place. And that's where we need to be at the end of the day.
Yeah, and when I hear you explain that, I think it maybe illustrates the point that the larger point that I'm thinking about, in that it's more complicated than it has to be. I mean, that's no different than the tax code, right? I mean, it's almost like if your taxes are beyond just, I get one W-2, I'm married and I've got one kid, you probably need an accountant to file your taxes and go through and make sure that it's being done right. I laughed at the letter that's been floating around from Donald Rumsfeld for several years, where he says, I'm smart, I'm educated, I'm old, I've been doing this a long time. I have no idea if what I am filing here is actually accurate. I'm doing the best I can. Here's a check, but I don't know if it's right, and neither does my wife. And it feels like there's some of that within the healthcare, and it's like it just doesn't have to be as complicated as it is. And I can't help but wonder, and this isn't a shot at hospitals at all, this is just like a big picture thought. I can't help but wonder if it has been created in this complicated way to benefit someone financially, whoever that someone is, whether it's insurance companies or hospitals or doctor salaries or anything in between. I don't know who it benefits, but you can't help but wonder if that's part of the reason that it's been made so complicated.
Yeah, and look, in any business model, there's going to be different variations in how that business operates and where the money is going. One example I've used before is if you go on a travel app, and maybe you go look at your Hilton app or your Marriott app or IHG for the Holiday Inns and those things, and you look at the pricing there for what a member of their loyalty program pays compared to the rack room rate for a hotel room, and then you go on Expedia, and then maybe you go on Travelocity or Orbitz or Hotels.com, VRBO, you're going to see a lot of different prices based off of how you're procuring those services or how you're procuring that commodity. Hospitals and healthcare are similar in that way, is that if you've got Blue Cross Blue Shield or Humana or Cigna, they've all negotiated different prices based off of maybe where they're insuring an employer. If they're providing services through an employer, particularly a large one, you may see a very different pricing structure, and it's just different people going to the market with very different pricing proposals, very different business intentions in some cases, and it's just a very different place. But it's it's not like it was 80 or 100 years ago for sure, but it is complicated.
Richard Robertson's my guest. He's president and CEO of the Mississippi Hospital Association. Spending cuts, DOGE cuts. We've talked lots about Elon Musk, the Department of Government Efficiency. They are trying to find inefficiencies and fraud and waste in all different areas. Everyone, I think, expects that there's going to be a change in the way that Medicaid payments are reimbursed to the state. It's a really complicated issue. We know that. Whether we're talking with the lieutenant governor or the governor or the speaker of the House, I think everybody expects that the state is going to get less money from the federal government than it's currently getting, and is going to be responsible for that shortfall when it comes to Medicaid. What are you hearing as we stand now, or are you hearing anything as to what those numbers are actually going to look like?
Yeah, there's a lot of speculation. Now, you've got a few things that have already happened, and those are, what's going on with DOGE and different government programs and grant funding that's being terminated. I know some of our universities and colleges are already experiencing some of that, where certain programs and grants that they've received, maybe for research, those have gone away or are expected to very shortly go away because they're seeing their program on the DOGE website on the list. Yeah. We've had that in our health department too. So, I think the health department, Dr. Edney, does a great job. They've gotten a couple $100 million in cuts that they're expecting from there. Mental health, I think, is $11 million. Department of Education has also experienced some cuts through DOGE. So
can you hold with me through a break one more time?
Absolutely.
Let's kind of wrap this up on the other side.
Yep.
All right. So we'll continue this part of the conversation when we come back. Richard Robertson is my guest, President and CEO of Mississippi Hospital Association. Mornings with Richard Cross, SuperTalk, Mississippi. We will wrap up the 7 o'clock hour when we come back with you. Richard Robertson with us. Appreciate your time this morning. Mornings with Richard Cross on SuperTalk, Mississippi. Don't forget you can join the conversation on the C Spire text line at 601-879-4395. So we were talking about what is rumored or speculated at this point when it comes to cuts in terms of federal government to the state level for Medicaid reimbursements or some of what's carried. Mississippi has made some decisions at the government level that the Hospital Association didn't necessarily agree with in terms of adding to the rolls of Medicaid in recent years. That may end up putting the state in a better spot financially dealing with some of this. So I guess I want to let you pick up kind of where you left off and just kind of take that where you think it makes the most sense.
Yeah, so look, I think everyone is expecting some changes in the Medicaid program. MHA for years has talked about the importance of expanding Medicaid to cover low-income working Mississippians. We haven't done that. So for other states that are looking at potential cuts to that population or changes in the state and federal match rates, that's not something we're looking at because that's not a program we've done. But there are other programs that are vital, and Medicaid has several different things that are being talked about at the federal level. One is reducing the provider tax. Hospitals pay about $450 million a year that helps the state fund their Medicaid program. We're pretty close to the ceiling that the federal government puts on the amount of money that we're able to contribute in provider taxes, hospital taxes. So if they reduce or lower that ceiling, then that's going to we're going to pay less in taxes, but we're going to have less federal money to draw down. We essentially stand in the shoes of the state of Mississippi as hospitals, and nursing homes do the same thing. And we help the state fund the state share that then draws down additional federal matching funds. So without that state money, you don't get the federal money. There's the potential for hundreds of millions of dollars to be lost because of a potential change in that program, which a lot of people right now are fully expecting. It's a 6% ceiling right now on basically a 6% of your net patient revenue for hospitals. If that goes down to 5%, 4%, 3%, something like that, you're gonna lose hundreds of millions of dollars in overall revenue that's coming into the state that helps offset the cost of hospital care and nursing home care. So there's an impact. I mean, that most of the cost in health care is labor. It just is. And so, we need the ability to pay and attract and retain healthcare talent, nurses, physicians, but also lab techs, respiratory therapists, speech therapists, physical therapists, pharmacists. Those are important jobs, and we've got to continue to attract them. So, I think you're going to see some things potentially change with work requirements. I think those are going to be put in place for some categories of eligibility. There's many, many dozens of different categories of eligibility, ways that people can qualify for Medicaid. We're concerned that average commercial rate payment for supplemental payments that I spoke of earlier, that's a lifeline. We're worried that some of the formulas there could change and that would destabilize the payments for hospitals. That's something that's absolutely critical for not just our big hospitals, but our rural hospitals too. That has been a lifeline. So those are things. I'm going to be in D.C. in 2 weeks and meeting with some of our delegation on the Hill, right, and hope to find out some more details. What we've talked about so far, right now has really not been any single plan. It's just kind of this general expectation of here's 5, 6, 7, 8 things that may happen. But I think they're still trying to figure a lot of this out, and they're trying to get to a number to save money and make these cuts so that it affects the whole budget.
So many
to be
different
determined.
directions. Yeah, so many different directions we go. We've heard people talk about block grants in terms of funding. Here's a certain amount of money, do with it as you need, and then you make up the rest. I guess maybe we'll leave it with this, and there's probably not enough time for you even to address this. I know that there is a frustration among people who are hardworking and they pay health insurance, and then they have to go to the hospital for an emergency, and it feels like a shakedown on how are you going to pay, how are you going to pay? And you've paid into your insurance and you get your bill and you pay your bill, and then you look to your left or to your right and you see somebody that has no insurance or is underinsured or whatever the case may be, maybe is not even legal, and they end up not paying anything. And it's like this massive frustration, and yet hospitals don't have the ability to turn away patients who need services.
That's right. Yeah, under federal law that was signed back in the 80s, EMTALA, it requires hospitals to diagnose, treat, stabilize, or transfer any patient that comes in through the ER, regardless of ability to pay. And, that is a very challenging, daunting aspect. Folks don't get to walk in Kroger and walk out with a bag of food just because they can't pay. No other businesses that I'm aware of operate in that way, so it makes it kind of tough.
Yeah.
But they do a great job. Our hospitals all over the state do a great job.
They certainly do. And some doing it with limited resources and still doing the best they can. Richard Robertson, President and CEO of the Mississippi Hospital Association. Thanks so much for your time this morning.
Thanks, Richard. Always enjoy it.
As